Immunomodulation of Propofol versus Sevoflurane-based anesthesia on deadly cancers. A quality improvement educational module by Tatiana Amaya and Jorge Valdes.
After this presentation, the viewer should be able to explain immunomodulation caused by anesthesia, summarize the harmful effects of anesthesia modalities on cancer patients, articulate evidence-based recommendations, correlate significance of using propofol versus sevoflurane to patient outcome, appraise clinical relevance of propofol and sevoflurane in different deadly cancer types, and lastly, develop perioperative anesthetic management most beneficial to cancer patients.
Let's talk about why Tatiana and Dr. Valdes decided to conduct this study. Background and education. The three most common cancers worldwide are breast, lung, and colorectal cancers, accounting for approximately more than half of all new cancer diagnoses in 2020. In vivo and in vitro experimentation analyses reveal anesthetic agents immunosuppress the functionality of macrophages, T cells, natural killer cells, and other immune cells after surgery. So what does this mean for you, the anesthesia provider? Well, the inhibition of immune response by anesthesia may contribute to proliferation of circulating tumor cells and have protumorigenic consequences on the patients you take care of. Therefore, utilizing the least immunosuppressive anesthetic agents in cancer patients could signify an overall reduction in cancer recurrence rates, tumor metastasis, and mortality rates, thus possibly improving cancer patients' survival rates. Now you may be wondering, how relevant is this to your practice? Do you truly need to alter your anesthesia plan when caring for cancer patients? How significant is this problem? What is the scope? In their research, Tatiana and Dr. Valdes analyzed all cancers and their impact. The top 3 cancers responsible for the most fatalities were included and carefully examined for this study. They discovered that a whopping 39.5% of men and women will be at some point in their lifetime diagnosed with cancer, and the current mortality rate of cancer is more than 158 deaths per 100,000 people. Breast, lung, and colorectal cancers combined make up nearly 60% of all cancer diagnoses. Ranking as the most deadly cancer is breast cancer. Breast cancer is the most common type of cancer. It makes up more than 1 of every 10 new cancer diagnoses every year and is the second most common cause of death from cancer among all women worldwide. Taking the number 2 spot for most deadly cancer is lung cancer. Lung cancer is the most diagnosed cancer globally, with the highest percentage of cancer-related deaths, and is the second most common cancer diagnosis in the United States. Lung cancer accounts for 12.4% of all cancers diagnosed worldwide. Colorectal cancer is the third leading cause of cancer in the world and the second deadliest malignancy for both men and women combined. So the prevalence of this problem is enormous, and extremely likely that you, as an anesthesia provider, will encounter these patients. Here in this study, they outline the latest evidence-based recommendations. Let's take a look at the literature.
At this time, please take a moment to pause and read over the research findings.
So what are the evidence-based research recommendations for anesthetic management of these patients? If you receive a patient with breast cancer, the recommended anesthesia is propofol tiva with a paravertebral block. In addition, ketorolac and beta blockers has been shown to be extremely beneficial in these patients and combined yield the best perioperative results. Due to the chemical nature of inhaled sevoflurane, it is no wonder why in lung cancer patients, propofol tiva is the anesthetic agent of choice. To optimize results, a paravertebral block is highly recommended. Newer studies have also found perioperative doses of Decadron to greatly improve patient outcomes. In patients with colorectal cancer, evidence-based research has shown time and time again that propofol tiva-based anesthesia is far superior to sevoflurane. This may be due to its lipid-based composition. Although controversial in the literature, research consistently indicates low doses of remifentanil to be beneficial in this specific cancer. Ketorolac has also proven to be efficacious and should be administered by anesthesia providers.
You may be wondering about other modalities and what their impact is on cancer patients. Tatiana and Dr. Valdes have extrapolated research over the past decade and combined the findings into concise charts. Let's review evidence-based recommended anesthesia for cancer patients and why. Propofol is a powerful antioxidant and anti-inflammatory agent which is extremely beneficial for cancer patients. Propofol preserves and enhances natural killer cell function, increases cytotoxic T lymphocytes, and decreases secretion of pro-inflammatory cytokines. Some studies have even found propofol to induce NK cell cytotoxicity in patients with colorectal and gastric cancers. Regional anesthesia is highly recommended in cancer patients undergoing cancer surgery. Regional blocks were found to decrease surgery-induced neuroendocrine responses by suppressing the hypothalamic pituitary adrenal axis and sympathetic nervous system. It also preserves cell-mediated immunity, which is associated with less immunosuppression and cancer recurrence. Regional anesthesia also blocks voltage-gated sodium channels, therefore suppressing signaling and tumor metastasis. Lidocaine. Numerous studies found lidocaine has anti-tumor and anti-angiogenic properties. It directly inhibits epidermal growth factor receptors, which are the target receptors for anti-cancer drugs. Lidocaine increases NK cells, inhibits cancer cells, reduces inflammatory tumor necrosis factor alpha, interleukin 1 and 8 levels. In systemic reviews and post-hoc studies analyzed, intravenous infusions of lidocaine increased survival rates and reduced cancer recurrence in patients undergoing cancer surgery. COX-2 inhibitors were also found to be beneficial adjuncts when caring for cancer patients. They increase natural killer cell cytotoxicity and promote cytotoxic T lymphocyte immune response. 2 medications were particularly studied in cancer patients due to their seemingly beneficial response. One of which was celecoxib, and evidence showed it reduced myeloid-derived suppressor cells. The other was ketorolac, which was shown to have a 5-fold reduction in breast cancer recurrence and now a standard recommendation in breast cancer patients. Fentanyl and remifentanil. Opioids are controversial in their benefits and impact on immunomodulation. However, studies have found fentanyl and remi to have antitumor-like effects in colorectal cancer cells. They inhibit tumor growth and cell invasion by downregulation of oncogenic microRNA 182 and matrix metalloproteinase 9 in colorectal cancer. And lastly, beta blockers. They reduce proliferation of liver cancer cells, preserve NK cell function when combined with non-steroid anti-inflammatory drugs in most cancers, attenuate regulatory T cells in breast cancer, and overall reduce the risk of breast cancer-related deaths. Didn't see a medication that's a staple to your anesthesia? It may be considered harmful. Let's review which modalities are harmful anesthesia for cancer patients and why. Sevoflurane, isoflurane, nitrous, ketamine, morphine, fentanyl, remifentanil, midazolam, precedex, dexamethasone, and high levels of concentrated inspired oxygen. At this time, please take a moment to pause and read over the research findings. What is the potential benefit of utilizing all these evidence-based anesthesia recommendations? What is the clinical relevance? Do they really have a high chance of survival?
Yes, they do. Survival in deadly cancers. Numerous data analyses were conducted on lung, breast, and colorectal cancer patients undergoing surgery in a nationwide study. The group of patients that received propofol were compared to those that received sevoflurane for 10 years after surgery. Cancer survival rates were then examined. Researchers found that patients with the best overall survival rates were those that received propofol. When comparing the first-year versus fifth-year survival rates, the propofol group had better survival rates in all clinical sites in both the first year and fifth year. However, after 5 years, there was no statistical difference between either group. Therefore, propofol is the superior anesthetic modality for these cancers, resulting in fewer complications and higher survival rates. But what about other cancers? Does this still apply?
Yes, it still applies. Systematic and meta-analysis studies comparing propofol versus inhaled anesthetics found that survival rates in all cancers were higher in patients that received propofol both at 1 year and overall throughout the 5-year study. Research also revealed higher survival rates in all ASA classifications 1 through 4 in the propofol group. Higher survival rates were also observed in the propofol group regardless of the cancer type or if they had cancer with or without metastasis. All of these findings support propofol's benefits in cancer patients. Regardless of the type of cancer, patient ASA classification, or metastasis, propofol consistently demonstrated higher survival rates when compared to sevoflurane. You may be wondering, does the inverse apply? If you give inhaled volatile agents, does that mean you're increasing your patient's chance of dying?
Yes, you are. Higher mortality rates were seen with sevoflurane and isoflurane. Mortality after cancer surgery was approximately 50% greater in patients who received inhaled volatile anesthesia than those that received propofol. Cancer patients that received propofol had a mortality rate of only 13.6%, whereas the inhaled anesthetic group was a staggering 24%.
So before turning on the gas on your next cancer patient, consider what type of anesthesia would you give. We hope these current evidence research recommendations were beneficial to you in your practice.
On behalf of Tatiana, Dr. Valdes, and Florida International University, we thank you for watching this presentation.